How's it going, modern renal therapy viewers? Dr. E here. I wanted to take a moment and list 5 things for this Top 5 Fridays, 5 impaired beliefs that you should address with your patient, typically on the first visit and ongoing, because people think that pain science or patient education is primarily for the first visit. And once you say it once or twice during the first visit, and you maybe even reiterate it a bit during the whole session, that it doesn't necessarily need to be reviewed again and again. So I got this information, I got this list from a slide in one of Adrian Liu's pain science courses on MedBridge, and I highly recommend all of his courses on MedBridge and MedBridge in general. And the link to that will be in the YouTube video or after the YouTube video and in the blog post that you're watching this on. So number one is that pain is always bad. And it's certainly, you have to start off with pain being an output and pain being directly proportionate to the amount of perceived threat. Now that isn't going to go over well, so there's certainly ways you can ease into that, because some people may think that you're saying pain is all in their head and it's not real. Every experience is real, just like saying that the color red that you see is real. You're experiencing that red, or you're experiencing that itch, but without the brain to perceive it, then and whether to tell you whether it's dangerous or not, it's the perception of threat that causes the output of pain. Okay, so pain being bad, it's not always bad. It's definitely an unpleasant and sometimes horrible sensation, but in the end, it's all about sensitivity. With acute injury, certainly you have to pay attention to these warning signs coming from the brain, but and that's absolutely necessary, and you're highly sensitive during that. When it comes to subacute and more chronic or persistent pain, there's often not inflammation. It's not acute and swollen, and it doesn't feel like it's pulsing. It's not warm to touch. Yet the brain is under continuous stress. It's under continuous threat, and it hasn't really learned that it's safe to resume positions and movement again. And sometimes after just having this reassurance, reading in a book, seeing it in pictures, hearing great anecdotes and stories and metaphors, a patient can start to feel better and move better. So definitely the perception of pain is not great. That is not a good thing, at least the feeling, the perception, but the output of pain, it may or may not be necessary because it's it's proportionate to perceived threat, but there may not be a threat any longer. The injury may have been long past. So number 2 would be that all pain must be gone before engaging in normal activity or movement. And certainly, one of the things I preach in modern manual therapy is that all manual therapy techniques, as much as possible, and techniques and exercises in general, should be pain-free. Now, that may or may not be possible depending on the condition. It could be a highly irritable peripheral sensitivity like a tendinopathy, and there might be some degree of discomfort with those loading exercises that are necessary. I think too many therapists confuse this, and on the other end, they think that all manual therapy has to be uncomfortable because you have to get to these mechanical or proposed mechanical effects where you're pushing into the plastic range of the stress strain curve, and that's not true. But if you take that whole pain-free message that myself and other people who are into pain science too far, you may think you may make the patient think that all pain has to be gone before they start moving, and that's not true. Again, especially in the case of a chronic or persistent pain state, they need to get moving and they need to push it a little bit to kind of raise those thresholds. And what I tell people is that if pain is all about sensitivity and they're already on board with that, in order to elevate or move those thresholds up so you have a bigger buffer zone where you can walk longer or sit longer or run further or bend your knee more, or bend further down, or whatever it is that the trigger is, you have to push it a little bit and you have to challenge the brain a little bit and make it realize that it's okay. And the brain and what it perceives and what the patient thinks are two different things. The patient may be totally on board with pushing it, but the brain isn't quite caught up to that message yet. So you grade the exposure to whatever their painful triggers are And you reassure the patient that, look, every time you've had a flare-up, it's always ended. So it's okay to push it a little bit. And I usually use a guideline of make it so that it's not more than 4 or 5 out of discomfort, and make sure that if you push it, it doesn't flare up for more than 5 minutes or so. And you'll notice that your pain threshold will start to increase. If you push it too much, above a 5, or it becomes irritated, and I'm careful always to say irritated, because patient might think that they're damaging something, or they're rupturing something. So if you irritate it and it's very sensitive after for more than 5 minutes or so, you just push a little bit too much. We'll just rest. You apologize, or you tell them if they're away from home, or if they're doing the home exercise program and they're away from the clinic, that you can just rest, or schedule an appointment right away, and we can try some passive techniques to kind of reduce that pain. Okay, so that leads to the next one. Number 3 is that passive treatment is the answer. And it's not that it doesn't help. And again, these messages can be taken both ways. Some people think that they need manual therapy, they need needling, they need ISTM, they need joint manipulation to put something back into place. It's not the answer, because it's not a permanent solution. Everything has the potential to work depending on how well you explain it, the patient's preference, if they buy into whether the treatment is helpful, and even if they see that the treatment is helpful on someone else, or if they've had experience with it in the past. But I always tell people that, no matter what I do, whether I scrape something or I stretch you in a certain way or put you in a certain position, don't attribute that to me. All I did is we were set an alarm in your nervous system so that those pain and movement thresholds are now larger, and I call that the window of improvement. So the window opened. So now you have a bigger buffer zone of activity or positions, and you can bend more, you can walk longer, you can stand longer. That window will start to close without further reinforcement. So, that's where the home exercise program always comes in, because the biggest message you can give to patients, and something I always tell people, is if you walk out of here moving and feeling better, it's going to be temporary. You have to keep up with it. You can keep that window of improvement open. And that's, again, more for the rapid responders, which most of your patients would be. For those truly persistent, chronic, centrally sensitized patients, that's a harder message, and they have to kind of learn to push it without flaring it up. And they're probably definitely going to have flare-ups, and you have to explain that to them. You can't say that they're not going to have a flare-up, because you have to be realistic about it. And they have to learn to accept that they may have some degree of pain or discomfort almost every day. It's just that they can get on with their life, and they can get on with activities and loading and strengthening, but they might have discomfort because we can't reset their nervous system as easily as we can with the majority of rapid responders. Number 4 is that pain will increase with any or all activity. So it definitely, a patient, even in persistent pain, as in chronicity, they've had it for a long period of time, they tend to think that everything makes them worse. And that's where being a great physio detective kind of comes in, with a very good history. Really interview them, find out what makes their symptoms better or worse. They may think it's everything, or they may not think there's a pattern. But if you start to even ask more close-ended questions like, what about bending? What about driving? What about texting? What about whatever, throwing? They may come to think, or maybe they won't know on the first visit, but if you tell them to keep a pain journal and kind of say like, hey, what were you doing at the time and immediately before you had an increase in pain, they may start to see a pattern, that it was after at a certain time of the day, and they spend the majority of time sitting, and they spend the majority of time standing, or looking down at a conveyor belt or something, depending on what their job is. So they may not notice a pattern until the first visit, but there's usually a pattern. There's usually triggers. And then you can also come up with, if there's triggers, you can come up with a plan to avoid those triggers, and then do something typically in the directional preference, which is usually novel and often opposite direction of those triggers. If they are often triggered with a lot of flexion activities, they might like loading or retraction for the cervical spine, for example. So they might think pain will increase with any or all activities, and that's usually not true. If they're in the triggering position, again, if they have a sedentary job and they're always standing in the same place, they're always sitting in the same place, or they continuously trigger it, their nervous system is going to be sensitive, and that window of improvement is going to be closed, or almost shut, and that buffer zone is going to be very low. So almost anything will be able to irritate them. But when they think about it, if they're better on the weekends or they're better first thing in the morning, not everything triggers it, right? And that's an important point to get across, because when symptoms are intermittent, that's how I almost tell patients they're a rapid responder. If you could even have 5 minutes to an hour of relief, we can typically extend that period of relief if you avoid enough triggers and you do enough resets. If you do enough resets, I call those +1s or +5s, depending on how powerful the reset is. And every trigger is a -1 or -10, depending on how long you do it or how bad the trigger is. If you do enough pluses and you avoid enough minuses, you go on the positive side of 0. You could even build up a buffer zone on the positive side of 0. And that buffer zone, similar to the window of improvement, and sometimes I draw like a number line for patients, or show them the window of improvement. That buffer zone you can build up by doing enough resets and avoiding enough triggers. 0 is when the alarm is triggered, and that's when the output of pain or paresthesia happens, and you lose motor control and you have decreased mobility. So the last one, or number 5, is that work is potentially harmful. And again, certainly people may have jobs where they're overly sedentary, they dislike them, they're highly stressed. All of those are triggers in itself. They're not always physical triggers, and pain is more than just a physical phenomenon. It can certainly be, again, triggered by physical things, but if they dislike their job, if they have a boss who's overbearing, if it's repetitive and they don't enjoy it, those are all things that contribute to the sensation of a pain experience and delay recovery or even prevent recovery completely. But if they like their job and they really want to get back to it, you have to get across that it's not that their job is harmful. It might be the lack of variability that they have, and they're doing too many negative ones and not enough positive ones. So if you've told, if they've been on this job for years or even months without any incident, you can get back to the job because the job's always the same. You have to have enough balance in it. I always say, if you have a desk job and sitting bothers you, but you've been ignoring your radiating leg pain, why don't you drink a huge bottle of water, like a 24-ounce bottle of water every hour? You may be ignoring your headache or your neck pain or your back pain, but you're not going to pee yourself. So once you go to the bathroom, you refill it, because chances are you're probably dehydrated anyway, like a lot of people in today's society are dehydrated. So every time, that the need to urinate is going to make you get up, and kind of that repetitive getting up kind of breaks up that prolonged sitting or those repetitive triggers, so you don't have as many negative ones. Combine that with just some simple walking around and some backward bends or some chin tucks, and often that's enough to break that pain cycle, okay? So those are the 5 things. Pain is always bad. All pain must be gone before engaging in normal activity and movement, and that's very, very important, especially even with discharge. Don't be afraid to just discharge your patients if they have some discomfort left, because you won't be able to get every single one of your rapid responders 100% pain-free. Passive treatment is the answer. It's helpful, but it's not the answer. It's not a solution. It's just a means to an end so that the patient can accept load and positions and activities threat-free. Pain will increase with any all activity, and work is potentially harmful. So again, I highly recommend Adrian Liu's courses on MedBridge. I hope that I've given you some ways to kind of head off some of these impaired beliefs, because these are some of the things that you have to address on the first visit and continuously if they have any of these, and your outcomes will probably improve because you're decreasing fear avoidance, and that will get them moving and feeling better faster. So if you like this video, definitely like it. Hit the like button, subscribe on YouTube, Facebook, check out Modern Manual Therapy on Facebook, Instagram, and YouTube, and check out edgemobilitysystem.com for all of our products, ebooks, and videos. Have a great day.